on social media during this, listen to the talks, but if you have any questions for any of the panelists or for myself or anyone in the room, tweet to us your question. And at the end of the panel discussion, we're going to have your questions, we're going to talk about them, okay? We're all going to answer them. So it's going to be somewhat interactive. It's the only way to get all of you in this huge hall to kind of ask your questions, okay? All right, so first, we're going to talk to Dr. Abbas Hussain, and we're going to listen to one of his terrifying pediatric horror stories.
This is a big space. I'm going to tell you a story about a 12-year-old boy. Let's call him Mohammed. It's not his real name, but it works. So I met him as I came on to my night shift. Okay. So I was the night shift doc. I walk in and he's sitting there. The day team that's evaluated him, and I had a concern for appendicitis. He had a tender abdomen. So they ordered a CT with a raw 90 contrast. I know you guys are shuddering over here, but keep in mind this is 10 years ago, and this is before we were facile with bedside ultrasound or what the surgeons were. So he's there sipping on his gastrograph, having a good time, and I speak to them. He seems to be otherwise well, other than some tenderness in his abdomen. So I let him continue sipping, walk over, see the rugrats and ankle biters that are waiting for me. And a little while later, he goes to CAT scan. And then you hear the thing you never want to hear, especially during a night shift in pediatrics, is rapid response, CAT scan 1. So we rush over, and sure enough, he's sitting there at the edge of the bed, flushed. The tech said he almost passed out. So what do we do here? Right, so first mistake, I just coaxed him down, let tongue to low flat, assured the tech, and did the scan. Now, just keep in mind that I never reassessed him. I never got blood pressure, never got a heart rate. He was not on a monitor. And you may think it's a 12-year-old kid getting a CAT scan of his belly. You don't need to do that. But if somebody's situation changes, you have to fall back on your safety net. And we kind of let him go and did a scan and came back. As I'm back here, now he's being rushed back by the nurse. He finished the scan, but he looks gray, ashen, pale. And he gives me that I'm about to die look, and I was like, oh my God. And for all you guys here, we've all been there. I had no idea what was going on. And I'm sure when you guys, as interns, as second years, approach a patient, you're like, oh my God, I have no idea. We've all been there, every single one of us. I bring him back and do the things that I know how to do. Put him on a monitor, put an IV, get a second IV, give him a fluid bolus. And yes, for all you people, he was normal saline, not lactate, don't fail me. Then I get a panic call from a radiology resident. It says the largest pericardial effusion that they've ever seen, and is signs and symptoms of tamponade. And I'm like, oh my God, I have no idea. I've never done this. I've had this kid with this. How do I do? What do I do next? So I call my consultants. I call the pediatric cardiologist, the cardiothoracic surgeon, and they're rushing in to take care of the patient. Meanwhile, I get a bedside echo, and sure enough, definitely agrees with what the scan shows. And then his pressure starts to go down. It's like 60 over 40 over nothing, and then he starts rolling his eyes back. Thank goodness the CT surgeon had rushed in the room at the same time. We were able to, so we grabbed all the setup that we had, took the 18-gauge spinal needle, put it in the subxiphoid space, everything we always train about, and the blood just rushes back. It pushes the plunger back, we pull back 20 cc's, another 20 cc's, another 20 cc's. And at that point, I'm like, oh my God, did I just harpoon this guy's left ventricle? Like, what the hell's going on? But then I look up, and the kid starts to pink up, he starts to get better. So we put in a catheter, we hook it up to our pleural back, and we get 2.5 liters of blood fluid out of this kid's heart. And he felt great. Now, think about it. It's a slow accumulating infusion, right? We rolled in taught as a large fusion and came in slowly, so kids can compensate so well. This kid is probably like, well, this is my life now for the past 2 weeks, and this fluid slowly building around his heart, and he's just thinking that this is what life is like. And he's getting through his day. Now we finally took that out, and it's like Superman. This is amazing. To cut it short here, so the kid goes up, gets a window, gets discharged a few days later with a pretty negative workup, and they found he had this side of viral myocarditis, causing a pericardial effusion. Months later, he's playing baseball in his 10th grade. So that's my story.
So that is insane. The guy came in, he's 12 years old, he's got abdominal pain, he's obviously appendicitis, and clearly the initial providers were probably great people who thought it was appendicitis, and lo and behold, the kid crashed. So I wanted to ask you, did you learn anything from this that will help you pick up myocarditis, or is this just the needle in a haystack, and this guy came in and there's no way anyone would have found this?
I think in this day and age it would have been very different, especially with bedside ultrasound. It may even have been worse because we would have examined his abdomen, did ultrasound at his right lower quadrant, and possibly even reevaluated and discharged him because he looked that great when we initially saw him. It would have done nothing more. Thank goodness we did a CT on it. Of course, if monitored closely, any intern would have put a probe on his heart and been able to tell that. But identifying it, thinking about it, is the hardest part.
Was he tachycardic at all?
I think he was slightly tachycardic.
Did you want to say something about the tachycardia?
I mean, just that's, I don't know, always one of the things with I hope, like, it'd be really terrifying if he wasn't tachycardic, because, like, I feel like that's my, like, safety net, is that I'm not going to send him if they're attacking. But, like, if he was, like, normal pulse rate, that would just be, like, absolutely terrifying. You could hold it, discharge that kid.
Yeah, I think the only distraction, I think he has a low grade temp, like 100.9. Would be low hundreds tachycardia, which just blown off on that.
So I think the important take-home points from that story is, one, kids look good until they crash. And I know we keep saying it, but anyone who's been doing this long enough who's seen a sick kid will say the same thing. And then the other thing is, when they look sick, they look really sick. So if a kid is not responding as they're supposed to and something doesn't fit, take that seriously. And I think you brought up a good point. Nowadays that we have ultrasound, we should be doing ultrasounds on kids more. I don't know why we don't do them as often, and especially with a sick kid. So that's a really great story. Thanks for the points. Laura?
Hi. Okay, my horror story does not start on a dark and stormy night. Instead, it started on a fairly mild shift, not a terribly stressful one. It's a peculiar one we have at our institution where the doctor's kind of a greeter doctor, kind of go around and see people as they're coming in and been waiting a little while, trying to make sure they don't wait too long, and get things started, say hello, let them know we care, and get their workup going, and then move on, which I kind of like. And also I respond to trauma codes. So anytime there's a call overhead, trauma notification, I'm going to run to that, switch gears, be all on. In this particular time, though, I didn't hear any call overhead, but my wonderful colleague, Jeff, comes and finds me in the back of the ER, and very straight-faced, I don't know, some of you know him, but he's not always the easiest person to read. I read nothing except, oh, we're going to go take a look at somebody, and he's covering kids, so I think we're going to go into the pediatric area. But instead, I see we're walking to the recess room. So I'm starting to change my mental state. Oh, we're going to the recess room. This is a sick kid we're going to see. And I walk in the door, doors open up, and it's Max. I see a 13-year-old kid looking in a great deal of distress, seeming to have difficulty breathing, and my brain in the background is screaming, holy shit, that's Max. And I'm telling myself, right, this is when you do that tactical breathing thing. Taking slow, deep breaths, holding my breath, letting it out. As I'm hearing the story, this is a 13-year-old boy who was hit in the neck with a football, and after about 10 minutes is developing respiratory distress and severe pain. He's already on the monitor, he's tachycardic, and I see him, he's panicking. And I know this kid. Like I said, this is Max. This is my best friend's 13-year-old son. Same class as my own son. So, my heart rate is almost as fast as his, but it's slowing down a little bit because I'm doing my breathing. And I'm thinking, as Dr. Levitan said, I have to compartmentalize this. That piece has to go in another box for right now. Right now, I'm dealing with this kid. So, but I do know him, and that has helped. So I look at him and I say, Max, it's Laura, look at me and tell me what's going on. What's happening? Are you okay? And he says, I can't breathe. I can't breathe. It really, really hurts. But he said it with words that I could hear. So that really made me step back a little bit, because I'm thinking as I'm talking to him and I'm hearing the story, I'm thinking in my head, okay, I'm going to have to intubate Max. I'm going to have to even take his airway because he has some kind of laryngeal fracture or something. As he's talking to me, though, I hear his words. I'm looking at his neck. There's no bruising. There's no swelling. I touch him. Max, you're going to be okay. You're going to be okay. But then I also put my hand on his neck. I don't feel any crepitus. I don't feel any swelling. But he keeps doing this kind of intermittent, looking like he can't get air in, kind of stridor, and then again, kind of crying and saying he can't breathe. I grab the ultrasound. This is telling me I have a little bit of time left, and it's saturating well, still tachycardic. I'm telling me I have some time. So I grab the ultrasound machine, which is right next to the bed, and I ultrasound his neck. There's no sign of air. There's no edema. I actually, for an old lady, I can find the cords, and I see the cords moving while he's breathing. So that tells me again, okay, I'm going to trust my instinct here. My instinct is telling me that this kid is not actually about to lose his airway. I think this is anxiety. And in my head comes episode 179 from EMRA, you guys can look it up, in which Rob Orman and Anand Swaminathan discuss a case where Dr. Orman gets a notification that he's getting a kid who's been hit in the neck with a lacrosse stick and is in respiratory distress. It's his chairman's son, a similar kind of high-stress situation. And it turns out the kid is having an anxiety attack. Similar thing in that once he realizes the kid is speaking to him, he knows he has time to wait. So as Dr. Orman did, I give pain meds. I do Decadron and racemic epi, thinking, can't hurt. I give him some Ativan. And it's getting better, but it's not perfect yet. He's still doing this, but it's better. So I'm going in the right direction, not the wrong direction. Then my friend comes in. So the mom arrives, but the mom is not just the mom, this is one of my best friends, who is both really relieved to see me, and also we're both aware that this is just not the way life is supposed to go, right? So I have her and her husband talk to Max, and it seems, that they're able to talk with it. Again, it's not perfect. It's not going away. So I have to take my friend out of the room and say, hey, this can go a couple of different ways. One way is we keep watching him, and he gets better and better, and this has a happy ending, and we go home. And the other way is I have to intubate him, which means I have to put a plastic tube in his throat, down into his trachea, and breathe for him. And that's a hell of a conversation to have with a really good friend. I mean, it's a hell of a conversation to have with any parent, but it does add that little extra bit when it's someone that you know and love. So, and then I also ask her, as I would with any parent, what do you think? Not what do you think I should do, but what do you think is going on with your child? Is your sense that he's really in trouble, or is your sense that he's more frightened and in pain than he is really sick? And she basically said, no, I think what you think. I also think that he's more anxious, and I wanna wait. Let's wait. So one of the good things about this shift is that I have because I don't have lots of other patients, I'm free to basically stay there. So I stayed at the bedside with him over the next couple of hours, and he gradually got better and better, and it did have the happy ending, and he was able to go home. That's my story.
Really big relief. I'm glad it did not go the other way because, yeah, I feel like it'll be different. Do you think, now question, because I actually have not yet had a situation where a really close friend or family I have to take care of, thank God, I don't want to be in that situation. Did you change your medical practice because it was your friend's son? Did you feel like you made different decisions compared to a normal patient?
I feel like I was very much aware that physicians often, we downplay our friends and family. We often think, I know my own kid had scarlet fever for 5 days before I decided it wasn't just a virus. So I was aware of that. I was also aware that, I didn't want to intubate Max. I didn't want to have to tube him. But and also at the same time, how would I live past him dying, right? How would we all have lived past that? So those things were in my head. But like I said, I've quoted Lemony Snicket before in this very venue, where I've said, basically, I'm going to be afraid of that later. It's really scary, but I'm going to be afraid later, and that's basically what I tried to do.
Yeah, that's that compartmentalizing, you recognize it, you put it aside, and you can deal with it later. And it's good that you kind of practice normal medicine because research studies have shown that VIP care is worst care. Treat every patient like you would any patient, and you'll do well with it. Thanks. So just a reminder before we go on to the next talk, here is our Twitter handle. It's ALL NYC EM. Tweet out some questions, and we should have a minute or two to answer some of your questions at the end, okay? So, on to Jeff.
So I was a beginning of second year Penn Fellow. We got a notification for a 2-year-old respiratory distress. And so EMS rolled in with this kid, they were bagging. He had some respiratory at first, we took him off, on a non-breather. He was in and out of quickly breathing, but breathing. Stats were in the 90s on the non-breather, but his mental status was poor. And the history was, it sounded like he kind of suddenly got short of breath. And it was pretty clear he needed to be intubated, and so we got set up. Upon exam, he had really distended belly, and so I thought they just insulated his belly as they were bagging him. So I asked for an NG tube, and as we're getting ready for an NG tube, before going to intubate him, here in the back room, no, his belly's always like that. He's got kidney disease. Why don't you ask him questions? We're here with the parents. The parents were in the room. They'd come in shortly after EMS, and I hadn't noticed them. So we kind of got off on a bad foot because I think they felt very ignored. Including the chronically ill kid they were very invested in. And so we tried to reset with them. I had a few minutes. They had better history, and they asked us to call his doctors at his coronary care center to make sure he really needed to be intubated. And he was still satting okay, so I decided we had time to make a few phone calls. We did. Then his sat started dropping. We said, no, you really need to be intubated now. We backed him back up, got ready with our RSI meds, and pushed our paralytic and our ketamine. And as soon as we paralyzed him, he got impossible to bag, and his sats plummeted. So the senior resident on took a look and couldn't see the cords. Sats are 70 now. So I stepped in and got a good view. And I had loaded a 4.5 tube, I thought appropriately sized, but it was too big to go through the cords. And so I asked for a smaller tube, but in the chaos, the intubation box had gotten knocked over, and no one knew where the tubes were, and so I stepped away from the head of the bed. Sats are 50 now. Tried to bag him some more. I was looking for a smaller tube. Back there, the father's still yelling, what's going on? Why isn't he intubated? What's going on up there? And I made a mistake that I can't still understand exactly why I did this. And instead of going down a half millimeter, I went down a 3.5 cuff tube, loaded that with stylet, went back to the bed, intubated him. It was easy. You got color change, you're bagging him, you hear breath sounds. But he kept on going down. 30, 20, 0, braided, lost pulses, started CPR. The father's sitting in the back of the room. And I knew the tube was in the right place, he was intubated, and knew he was having a hypoxic bradycardic arrest, and that all we had to do was oxygenate him, and we couldn't do it. I don't know if any of y'all are athletes of some sort or another. I used to climb a lot back in the day, not so much anymore. There's a moment when you kind of run out above like your last piece, like in a difficult area, and the thing that's holding you on, whatever you're doing, is the simple belief that it's going to work out. And then you lose that, and the next thing you know, you're just falling. Nothing really changed your objective circumstances except your situational frame. I never felt that in resuscitation before or since, but in that moment, I just, like, this kid's gonna die. I'm gonna watch this kid die. His father's teal in the back. And couldn't troubleshoot, couldn't think past what to do next. Just like, we have a tube in, can't bag him, we can't oxygen him, he's just gonna die, nothing else to do. And someone else in the team suggested trying to create a bigger tube, but maybe the 3.5 was too small. I love to say I was a hero in that case, but in fact, anesthesia had come down from pediatric code, as had most of the hospital, I guess, actually, at that moment. And so rather than try this complex psychomotor task with the mindset of defeat, let somebody else take over. And the anesthesia resident debated the 402, and we almost immediately got roused because SATs came up. He had a really stormy course, it was hard to oxygenate. He had really high airway pressures. It was really tough to manage in the ER. But he went on to do okay. And so afterwards, we got him packaged up and shipped out finally to the coronary center where he got most of his care. And the father and I had a chance to talk for a little bit. I said, I'm sorry this happened. I'm sorry that you guys are going through this. This is awful. And, I have a kid at home. I was 4-month-old or 5-month-old at that point. So I can't imagine what this is like. His response was, go home and hug your kid tonight. I didn't know exactly how I meant it at the moment. I heard it, kind of sounded full of venom. I don't know. I thought about that case really constantly for several weeks afterwards. There was a lot of learning points. Obviously, prepare up and down tubes and go intubate a child, so you're not grabbing from the first one doesn't work. I thought about the physiology of it a little bit. I think that his polycystic kidneys were so large, he had such high abdominal pressure that once it took away the work of breathing his diaphragm, the muscle tension of his diaphragm, that it just became impossible to bag. Probably better positioning, sitting upright would have helped. I thought about how the bag used kind of pop-off valve, and so we couldn't get more than 20 cc's of water pressure. And I didn't take the pop-off valve off. Think about it at the moment, but maybe that was part of the problem too. We could get enough peak pressure to open the airways up once we paralyzed them. And about the sort of cognitive failure of accepting defeat in the moment, and how to, going forward, recognize when that's impending and to fight that off and to work past it, as we learn to do in other realms of our lives. I think as these cases do, it sort of faded to the forefront of my mind, and became something I thought about less and less frequently. And a year later, I got a card from an address in California, which I assumed was just an applicant thanking me for interviewing them or something like that, because it's that time of year. And I opened it up. I don't expect much. And there was a picture of a boy, big belly, and his little sister, his first day of kindergarten, or nursery school, whatever it was, I guess, like preschool. And a thank you note from the parents saying, thank you so much for saving your child, it meant so much to us. And they sent me one every year since then. And I guess the final lesson of that was you never know in the moment the impact you're going to have on the people you take care of. And none of us go into it for the recognition or gratitude. When it happens, it's great. But you never know what's going to happen. And people you think maybe hate you, feel like you really messed up, you wonder how you did, might have a totally different perception of the situation. And conversely, when you think you did a great job, I think you really didn't. Whatever.
Oh, that's a very tough story. I'm really amazing. Kid went on and is having a happy life, and I just feel like it must have been terrifying in the moment, especially with, you have a kid that's crashing. You're thinking about, at the time, you were feeling some doubts about yourself, which is terrible to go through, and I'm sorry you had to have a case like this. When the parents were in the room, that's another layer of stress. So how did you, again, I feel like a lot of what we're talking about today are those oh crap moments. How do you compartmentalize? How do you handle under pressure? How did you, can you maybe teach, the residents in the audience, how did you manage the angry, freaking out, scared dad who is, yelling at you and saying all of these things, who has a sick kid, who's taking care of this sick kid? It's not just a normal kid who crashes. I mean, this dad is so much more involved. How did you manage him in the moment?
We didn't manage it, to be quite honest. I think we could have certainly, I think his presence contributed to the overall tension in the room. I think from my standpoint, and maybe this is good at this moment, let myself become quite task-focused or task-saturated on intubating and to a lesser extent running the resuscitation. I was able to kind of tune him out, I guess. But I mean, you never really can tune that out, and probably it did contribute to the overall sense of confusion. We could have done a better job, I think, of trying to at least, have someone talk to him or settle. There was no one really seeming like someone assigned someone to the parent. But we had plenty of manpower in that room that we were not able to. We did not do that. But no, I think like you talked about sort of kind of become very task focused and tune out the rest of the things that are going on as in any kind of other performance activity. And I think it was easy at the moment to sort of allow myself to build a little bit of tunnel vision to tune out.
Yeah, I think that's what you had to do to get the job done. I'm glad we've been able to learn from such great attendings. Let's give them all a round of applause. And teaching us how to manage them. And our job is tough, right? Because for the most part, every day kind of starts to feel like another day. Appendicitis, renal colic, rule out ACS, you admit them. But once in a while, you're going to get these cases. And I think that's the tough part of our job. But stay focused, make sure you build, kind of as Dr. Levitan was saying, a nice life for yourself outside of medicine to keep you going when sometimes your career might not feel like it's as strong or as good as you'd like it. But we got overall a pretty great career because these 3 docs in here were able to save some really sick kids, so that's great. I want to see if we have any questions from the audience.
Yes, so Patrick in the audience basically asked the question to all the panelists actually. What do you do when you have that deer in the headlights feeling? How do you think about that situation? Aside from going back to just the ABCs, which you're all told about, what else can you do when you have that deer in the headlights feeling?
Well, I can tell you one thing, I really actually do that breathing thing, that tactical breathing thing, when I know I'm even getting ready to come up here, or getting ready to walk in a room as I'm preparing the room for the recess. Part of that preparation is preparing me, and I start the breathing. I breathe in for 4, hold for 4, out for 4, hold for 4, and it works. I feel it slow my own heart rate, and I also try to think through the worst case scenario. So every time I'm trying to prepare for a situation like that, or having that deer in the headlight feeling, that like, oh shit, it's Max, I think, okay, it's Max. What am I going to do? Either if I'm going to intubate, am I going to cry? Am I going to wait? Am I going to medicate? Try to go, what could go wrong if I try to intubate? Well, I could not be able to get the tube in. I might have to cry. What could go wrong if I give him an anxiolytic? Well, he could lose his airway because I've actually sedated him, somebody who needed all that energy to breathe. So I try to prepare in my mind what's going to go wrong and be ready for it. But really the breathing thing is the first step. I think the first thing I try to do is get my own body under control.
Very well said. Now, one other thing that I will add on to that is also, I can be quite impulsive at times, so I work hard to not act and to not do the first reaction, what I want to do. So, always have my first reaction of thought, wait, pause, take the breaths, and then reassess the situation, and then go do whatever action I need to have done. But believe me, every single person in this room has been in those situations when you're looking at oh my God, what am I going to do? And there's no magic pill for it, but definitely getting your bearings about you and not acting.
We also have the SurveyMonkey URL, so you can type it in. The reason you want to register is we have some little prizes as the conference goes on, but at the end of the conference, we're going to have some major prizes, including money to go to a conference. Residents love money, so register. Let's see if we have a name.
Greg Widener from
Greg Widener.
From Hackensack.
Right? And he's getting a
Pulse ox.
portable pulse ox monitor. Okay, great. Because we can never find them, they never work, right? Alright, so you guys are going to go off and you're going to break. Remember, so we're going to need you to come back. What time do you want them back?
We'll announce it.
Okay, we'll say 11:15.